positive, capital L, capital R positive, for ST segment elevation on EKG in an adult male in the ED complaining of chest pain. LR positive stands for likelihood ratio positive. So what we're trying to do is we're trying to figure out what's the likelihood ratio positive if an adult male comes in the emergency department complaining of chest pain, we do an EKG and find ST segment elevation. Anyone find an LR positive, a number? Nothing. So your browser found 0?
That said missing.
Everybody's got nothing?
Well,
I got a journal.
Yeah, I have a elevation. This is the same.
How do we get everybody, when I did this with the faculty, every faculty member got something to come up.
So I guess.
Anyone find anything to come up? Raise your hand.
Well, something, yeah.
What did it come up? What did it come up?
It says ST segment elevations, always a marker of acute myocardial infarction, question mark. But
That's what I need to.
Anyone find anything that says LR positive?
Yeah, I got
22, yeah.
95% confidence interval between 60 and 30.
LR positive for 22? Anyone else find an LR positive? What was it?
22.
Oh, I have the same one, 22.
Anything else? 4.7. Anything else? All right, so what browser were you using?
Yeah.
Safari? What browser were you using that said nothing came up? Who said nothing came up? You?
Well, they're looking at journal articles that I wasn't looking at. So when you scroll down, you can see that they're journal articles, and then in the,
When you scroll down, something came up.
yeah, and like the,
Like synopsis.
I don't go to the bottom. The bottom of Google is not good. All the good ones are at the top.
All the top is fine.
Okay.
I found a journal article with a whole bunch of other
Okay, so you found an article. What's the name of the article?
Systematic review and modeling of the investigation of acute and chronic chest pain in primary care.
And it has a whole lot of LR positives listed.
Yeah,
No, I believe you. You've got a table there, a bunch of LR positives for a bunch of diagnostic tests. Any other LR positives you found besides 22 and 4.7?
I have one that says 0.019.
No, that's LR negative.
No, it says LR plus.
No, that's not it. Not for this problem, it isn't.
there's a lot of different ones in this article.
A lot of different LR positives for the same issue, or a lot of LR positives?
I don't know. There's
Okay.
just a lot of other policies.
All right, so what are we doing? We're trying to model what you would do if you're in the clinic or you're on the ward seeing patients, and you're wondering about using a diagnostic test, and you're trying to figure out how good is this diagnostic test. All right? Now this is a new way of thinking. I know for a fact this is a new way of thinking. But I'm going to try to convince you over the next hour that it's worth thinking this way. The way you want to think and the way you've been trained to think is to ask the question, what's the best diagnostic test in this situation? Okay? And you'll ask that question a lot, and you'll ask it of yourself, and you'll ask it of your peers, and you'll ask it of your attendings when you're on the wards and in the clinics, and they'll give you an answer. But the answer probably won't be based on the highest likelihood ratio positive. That's the highest likelihood ratio positive is the right answer to that. Whichever test to answer the question you need answered with the highest likelihood ratio positive is the best test. Right? You remember yesterday, I said it takes 20 years to get something found, data, evidence for it, included in practice? Likelihood ratios for diagnostic tests is one of those things. Most people practicing medicine out there don't even know what a likelihood ratio positive is. If you ask them, they wouldn't know. Okay, but it's so remarkably useful. When we were doing this with the faculty a week or two ago, Laboratoire went to the App Store and found 4 or 5 apps for likelihood ratios. I downloaded one of them last week, and it was kind of useful. I haven't downloaded them all, but I want to warn you that there are going to be apps out there, and you could put one on your phone, and you could use it like that. I'm going to teach you today, if you can find the likelihood ratio, how to do this all in your head. But you can find an app that'll do it for you. Not only give you the LR, but it'll also make all the calculations. I just don't know which app is best. All right, so we've got 22 and 4.7. Did anyone else find an LR for this?
So the article that I found, I read it a little more, and it's got an LR positive for each different symptom that is predictive of an acute MI.
Yeah. And so does it have ST segment elevation or depression?
Yeah.
What is it?
22.
22. What else? Did you see it? It's the same one?
New ST depression is 4.5.
4.5.
Q waves are 22.
I don't want the Q is, I just want ST segment. So we got 4.7, 4.5, 22. Any other number?
You guys do 24.
What?
Maybe 24?
Maybe 24? What do you see? Maybe 24.
Well, because I'm trying to load the article, but all I get is the ... LR plus equal 22. So I don't know if it's exactly answering your question yet.
Anything else?
I found ST depression 2.79.
2.79?
I found 6.1.
6.1?
I saw ST elevation was the most effective EKG feature for determining MI with an LR plus 13.1.
13.1. Okay, that's good. All right. All right, that's good. Now, you remember me saying a few weeks ago that one of the most difficult things about clinical medicine is it's so ambiguous. It's so damn ambiguous. It's not like biochemistry. And this is a great example of the ambiguity of clinical medicine. And we're going to walk through how we're beginning to think about diagnostic testing. And I'm going to try to make you a little bit more comfortable with this ambiguity, okay? So you guys probably don't have the experience of 4 or 5 journals coming across your desk, coming to you. I have 5 journals coming to me every month, 5 new journals coming to me every month. And I want to know, is there anything new in these 5 journals that I need to know about? And I decide that by reading the titles on the front cover. And if it looks like something I want to know about, I circle it, lay it over here until I have time to pull it out. And they will fall into one of those categories I listed on the board the other day. Therapy, prognosis, diagnostic testing, systemic reviews, or meta-analyses. And if the topic is something I want to know about, I'll circle it and put it over the side. When I get it out to read it, I go through the process I'm going to talk about today to try to decide whether it's something I want to read more carefully, pay attention to, or whether I just trash it. Okay. We talked yesterday a bit about,
I think you're in the wrong, you're in the
hitting the wrong thing.
wrong.
That's pretty typical. Oh, pretty typical of me. So I talked about this yesterday. It takes 20 years for practitioners to, do something. Here's some data. Several years ago, I was running a committee. I was appointed as chairman of a committee to look at all the hospitals in Oklahoma to test whether they were discharging their patients after MI with beta blocker. And we were hired to do this by Medicare. All hospitals reporting in Oklahoma, 74% of the patients had been discharged on a beta blocker. This was at least 20 years after the data came out that you need to discharge someone with an MI on a beta blocker. At OU Medical Center, it was 99%. Okay, so the doctors at OU Medical Center were doing a much better job than the doctors in general. But look at this. Pneumococcal vaccine to people over 65 when they left the hospital. In the state of Oklahoma, 61% left with evidence that the people over 65 were current on their pneumococcal vaccine. At OU Medical Center, it was only 60%. We weren't as good as the general hospital population out there, or we were about equal. So it doesn't seem to matter unless you're focused down in a subgroup. The reason beta blockers were used on everyone who left the hospital at OU Medical Center is that everybody was discharged by a cardiologist. Whereas in the state of Oklahoma, they would have been discharged by general internists, family physicians, hospitalists. They weren't cardiologists. And cardiologists would be expected to be behaving this way with beta blockers much more than, let's say, a generalist. And OU Medical Center might not do as well with something as general as pneumococcal vaccine because all these patients are being attended to by specialists, cardiologists, nephrologists, gastroenterologists, neurologists, right? Infectious disease docs. The number of generalists at OU Medical Center is pretty small. But the data support what I said the other day. It takes 20 years for us to incorporate into our practice. All right, so we're going to talk about how to sort of think about a article in an article over a diagnostic test. How does this come about? This comes about by some clinical researcher or some specialist says, okay, I've got this new fangled machine. We call it a Doppler ultrasound. And I wonder if we could use it to diagnose deep vein thrombosis. Okay, and to do that, we have to know, well, how do we make the diagnosis? What's the gold standard? What's the gold standard for making the diagnosis of deep vein thrombosis? And at the time, the ultrasonographer came up with this. The gold standard was venography. So if we wanted to know if someone had deep vein thrombosis, we'd send them to the radiologist. They'd take a needle and put it in the venous system. On the side we thought there was a clot, and we'd inject this stuff that goes up in the veins and see if there's a clot up there. So that's the gold standard. But now we'd like to see out here, we want to see if ultrasonography will work. So by definition, by almost, it's not arbitrary because there's an algebra associated with it. But every time we're trying to look at a new diagnostic test, we put the new diagnostic test over here, plus minus, and we put the gold standard here, plus minus. So So we do the gold standard and we do the test we're wanting to do. We're wanting to find out about ultrasonography. We do both tests on every patient, okay? And we're testing how good is the ultrasound against the venogram. Make sense? Everybody with me so far? So here's the 2x2 table. You've got the test on the left, we're gonna call it ultrasound. We've got the gold standard up top. The gold standard would be the same as disease. Right? So if the gold standard is positive, we say they've got the disease. If the gold standard is negative, we say they don't have the disease. But that's not actually true in reality. That's not actually true, but it's the best we can do. In most illnesses, it's the best we can do. Try to point out how ambiguous this stuff is. So if the test that we're looking for is positive and the gold standard is positive, that's a true positive. Now we're talking from the perspective of the ultrasound. The ultrasound's positive, the venogram's positive, that's a true positive. If the test that we're looking at, the ultrasound is positive, but the venogram is negative, it's a false positive. Because the test was positive, but the disease wasn't present. So it's a false positive. If the disease was present, but the test we're interested in was negative, it's a false negative. The gold standard is as if we got a phone call from God, right? And so if the test we're interested in is negative and the disease is not, it's a true negative. These are definitions, ways to think about the gold standard equivalent to the disease and the test that we're trying to study, okay? The way I think I learned this best was I tried to put myself in the position of saying, what would I do if I had a new test and I was trying to figure out how good it was, right? I'm designing the study. How would I go about doing it? So we'll get to those things when we start answering the questions. That might be a way to think of it. Now there's a term called operating characteristics. You might hear someone say, well, let's get an ultrasound for this deep vein thrombosis. And someone might say, well, what are the operating characteristics for that test? Or they might say, what's the sensitivity and specificity for that test? Or they might say, what's the likelihood ratio positive for that test? And it just depends on where they are in the spectrum of using this data. Okay? Has everyone heard the terms sensitivity and specificity before? What were the circumstances? Bacterial culture. What else?
We went over it in lab med earlier.
So you went over it in lab medicine, probably with Neil? No. Who? Reggio did it. She used the 2x2 table.
No, she explains what I'm
What's the terminology?
Okay, so someone tell me what you learned about sensitivity in that setting. Have you been tested on it yet?
Yeah.
So it's gone.
A test can be sensitive without being specific, or vice versa. The test can be specific without being sensitive, and you have to take into account like that. The specificity or sensitivity of a test can indicate whether you're going to have false positives, false negatives, that sort of thing.
Okay.
We got the formula too.
Yeah.
True positive over true positive plus false.
Okay. All right.
Yeah.
All right. So let's back up just a minute. We're gonna do 2 or 3 things here in about 5 minutes, hopefully. what I would do if I would, is I would forget where true positive, true negative, false positive, false, I'd forget that stuff. I would remember A, B, C, and D. I'd remember where they go on this 2x2 table. Remember the 2x2 table. It's the thing that's most important in both diagnostic testing and treatment. So remember the 2x2 table, A, B, C, D, okay? And then the definition of a sensitivity is A over A plus C. Now, what I can guarantee you is this will be on pants, all right? The accrediting body for a PA program like this one requires that we teach evidence-based medicine. And evidence-based medicine is huge in terms of content. So PA educators or the accreditors or the examiners have to figure out what am I going to test about. And what they will decide to test about more commonly than not is they'll make you, they'll give you numbers in a 2x2 table, or they'll give you some numbers somehow that you can put into a 2x2 table, and they'll say, what's the sensitivity of this test? That I will do when I examine you. I'll make you calculate the sensitivity, and then you'll pick it out as among the A, B, C, or D. And specificity is D over B plus C. Sensitivity and specificity is solving that 2x2 table vertically. All right? All right, now, listen to this carefully. Sensitivity and specificity do you zero good. Zero good by themselves when you're trying to think about clinical medicine. And that's all you're going to be doing for the rest of your career. Just think about clinical medicine. Sensitivity and specificity don't do you any good. When I was in medical school and residency, we knew this stuff. Okay? We knew this stuff. And it was lectured to us, and we learned the definition of sensitivity and specificity, and people would say, well, this test is 86% sensitive, 92% specific, but it never made much sense to me to have that information. I don't know how that helps me. I know that if both of those numbers are really high, it's good, but if one of the numbers is high and one is sort of midway, I don't know what that means exactly. And then here's what would happen. You're going to see this happen. I would be willing to bet $100, not 1,000, bet 100, that this is going to happen to you in the next 2 years. You'll be somewhere in a clinic, on the wards, be a group of people around. You'll be talking about a diagnostic test, and there'll be two people sort of arguing, no, I think we ought to get an ultrasound. No, I don't know. Maybe we ought to get a D-dimer. Worrying about, let's get a D-dimer. Well, what's the sensitivity of a D-dimer? I don't know. I think it's about 88. What's the specificity of a D-dimer? I don't know. Maybe 60. I don't know. And then you'll get to talking, and then you have some numbers for the sonogram, and the conversation will keep going. And you've got work to do. You've got to get something done. And you listen to this, and pretty soon it disintegrates, and people walk away, and nothing was really determined. Happened to me 100 times during 3rd and 4th year medical school and residency. People get in there and start talking about sensitivities and specificities, and they don't know what the hell it means, and they don't know what to do with it. Okay, the reason they don't know what to do with it is really, really simple. The 2x2 table functions algebraically. You don't have to know the algebra, but it functions algebraically, and the algebra with which it functions is only useful with odds. We talked about this a little bit yesterday, right? That'll work pretty well if you're at the racetrack, but it doesn't work in the way our brains have been trained to work clinically. Because it doesn't work with probabilities. And we're thinking they probably have it, they probably don't have it, or it's a coin toss. That's kind of what we're thinking. They probably have it, they probably don't have it. I don't know whether they have it or not. That's how our brains are working. Sometimes we say they probably have it and we just go ahead and treat them. If the treatment's pretty benign, shit, I don't have to have a test. I'm just going to treat them, see if they get well. But we don't think there are odds. So, since we don't think what's the odds, sensitivity and specificity, since they're designed off this 2x2 table, don't help us. That's why those conversations don't ever go anywhere. Because the clinicians don't know what to do with sensitivity and specificity. They just know what the definition is and they talk about it a lot. It makes them seem smart. Okay? But it doesn't make you any smarter because your brain doesn't know what to do with it. Okay. I could prove to you that this is true. Likelihood ratio positive is 1, a specificity, a sensitivity of 1 minus specificity. I could prove to you that's true using the algebra of the 2x2 table, but it doesn't matter. Just believe me, it's true. This is a definition you have to memorize. It's no different than having to memorize that the phrenic nerve comes out of C, 3, 4, and 5. 3, 4, 5 phrenic drive. That's what moves the diaphragm. You just memorize it. You don't have to know much more about it. Now the cool thing about the definition of likelihood ratios is that sensitivity always is in the numerator. And specificity is always in the denominator. So if you're given a 2x2 table with numbers in it, now you know how to calculate the sensitivity, how to calculate the specificity, and from that, you can now calculate the likelihood ratio of positive and negative. You just have to remember the definition of likelihood ratio of positive. That's how I remember it. I just remember the definition of likelihood ratio of positive. Sensitivity is always in the numerator, so it's sensitivity over 1 minus specificity. If I'm going to go for the negative, it's 1 minus sensitivity over specificity. Pretty simple, pretty easy to remember. That's easier to remember for me than A over A plus C and D over D plus D. But I think for this course and for PANTS, these are the two most important things to remember. This is probably more important than this. They'll probably make you calculate the sensitivity of a diagnostic test or the specificity. So you got to memorize those things. Okay? Okay, so I thought I'd change this. This slide should say, refer to page 25 on your primer. So on D2L, there's now a file that contains EBM primer, or EBM, a short primer, or something like that. It says short primer and EBM are in the title. Okay, so that's an electronic book, and it's pretty small, and it's written, I've written it, and it's basically, it's it's an abbreviation of the book that I showed you yesterday from McMaster, okay? So it's smaller, easier to read, it's shorter to read, and there'll be a chapter on therapy, there'll be a chapter on prognosis, there'll be a chapter on diagnostic testing. And so if you want to spend some time really getting into this and figuring out a little bit more about it, you just pull up that primer and go to page 25 and it'll make these definitions. Okay. Now, we're going to use all the stuff I've just covered in a few minutes. All right? Well, actually, we probably ought to take just a quick break and use it now. Let's go back to that adult male in the ED with chest pain, okay? You envision yourself that you're in the ER and this guy's coming in, he's got crushing chest pain, and you get an EKG, you just tell someone, let's get an EKG while you're taking the history. You're doing things simultaneously in the emergency department. So someone's hooking him up to get an EKG while you're getting a few more specifics about his chest pain and trying to figure out what's going on. Now, there are a whole lot of tests. Your question is, does he have a heart attack, right? That's your question. Because I gotta do something about it, and it's time specific. I gotta get into the cath lab and see if we can open that vessel before he develops a Q wave, right? If he's got ST segments that are shifting around, and he's got injury pattern, we need to get him to the cath lab and open that vessel before he kills off that visual. So, the first test that's rapidly available is the EKG. You also will have people coming in to draw a troponin, because the troponin test is also helpful, very helpful. And you want to get that to the lab quickly so they can get it back, stat troponin, stat EKG, get it all done. Okay? So, you've now spent, I don't know, 4 minutes taking his history, trying to figure out, does this chest pain sort of fit angina? Does it fit myocardial pain? And you are thinking to yourself, probably has it, probably doesn't. Don't know. Okay. So I'm going to ask you to start using those 3 categories in your clinical thinking. And they're going to, can I erase this now? Mm-hmm. They're going to correspond with these probabilities. Now, realize I'm making this up. Not me, someone else made it up before me, but it's arbitrary, right? But what we know after we've been practicing medicine for 10, 20, 30 years, what we finally are willing to admit is that while the history is the most important diagnostic information we're going to get, it's probably not much better than getting us in these 3 categories. It would be preposterous for me to say I can take a history and I can decide it's 72% likely that they have this disease. That's not the way the brain works, and that's just not true in clinical medicine. So they probably have it, they probably don't have it, who knows? Okay? Now what I said earlier is that sensitivity and specificity, and therefore likelihood ratios, don't work with probabilities. Can't use them mathematically with probabilities. Bummer. Our brains think of probabilities. So what we got to do is we got to turn the probability into an odds so that we can use the 2x2 table. So we can use the sensitivity and specificity in the form of likelihood ratios. Okay? You turn a probability into a odds by taking the probability and dividing it by 1 minus the probability. So a probability of 80% is equal to an odds of 4 to 1. We use the same formula for 50. 0.50 over 0.50 is 1. 0.20 over 1 minus 0.20, 0.25.
For the second one, do you not subtract it from the one? You do.
I'm sorry? Someone asking a question?
You
Got it? Wow, I thought I was going crazy. Yeah. You don't have to worry yourselves at all about this conversion between probabilities and odds. You really don't have to. I mean, if you want to, you just remember that it's the probability over 1 minus the probability. That's how you get an odds. But what you do have to remember is 4, 1, and 0.25. You just remember those three numbers. 4, 1, and 0.25. Those are the numbers you need to remember. Now, this 80, 50, and 20, what do we call those? We call those the pre-test probability. That's the probability you've come up with after you did your H&P. While you're standing there taking the history and see what you're doing simultaneously is you're at the bedside with this guy with chest pain and you're asking questions and you're also putting your thumb on the costochondral junctions and you're pushing and you're seeing if it creates pain. Because if you can create pain with your thumb on the costochondral junctions, they've got something else probably, right? And you're trying to rule in, rule out, and you're doing it by a variety of maneuvers. They're overlapping each other. You're not doing them in sequence. You're doing them all at the same time. That's how a clinician works. And that's how the brain is better than a computer, is it can think on multiple levels at the same time. But when you're through doing all that, you have a pre-test. Now thinking of the test as being the EKG, you have a pre-test probability, and it's either 80, 50, or 20. If you put your thumb on there and the guy jumps off the table when you press on his second rib costochondral junction, you've gone from 80% down to 20%, or at least at 50, because boy, you've just picked up costochondritis, right? But you finish all that H&P stuff, and you're in one of these pre-test probabilities, but you can't use your likelihood ratio without pre-test odds. So you remember 4, 1, and 0.25. 4 is, he probably has it. 1 is, who knows, it's a coin toss. 0.25 is, probably doesn't have it. Now all you have to know is, what's the likelihood ratio for this test? And so, just pull up your phone. Now, what I suspect, I don't know this for a fact yet, but my guess is that one of those apps will be a table of LRs, okay? And you can usually find the LR positive and the LR negative by just Googling it, okay? You can just Google it. Why do we have so many? We've got it all the way from 2.7 to 22. Why would that be? Why would it be listed as all the way from 2.7 to 22? Where did they come from? Where does this likelihood ratio come from? It comes from this 2x2 table. Someone did an experiment, and they did the test that you're looking against the gold standard, and numbers wound up in these 4 quadrants, and then they did the arithmetic. And in one study, ST segment elevation, or LR, LR positive came up 22. On another study, it came up 2.7. Well, why would that be? Because there aren't any perfect studies. There aren't any perfect studies in clinical medicine. Clinical research is very different than bench research, because in bench research, we can control for all the variables except the one we want to measure. In clinical research, we can't control for shit. We can't control, because we're dealing with human beings, and so we can't control for all these things. So it's not unreasonable that LRs are all over the map. We'll see if it matters. We'll see if it matters quickly, okay? We now take our likelihood ratio. Let's start with a likelihood ratio. First of all, let's round these things off. We're going to think of 3, we're going to think of 4, we're going to think of 5, 6, 13, and 20. We're not going to use those, we want to round everything off. Why is that reasonable? Why is it reasonable that I round all this stuff off? Because I started with a rounded off number. I started by putting it 80, 50, 20. Gee, Christmas. I'm already guessing. So it's okay for me to guess again, right? I'm really comfortable with this ambiguity. All right? So I multiply this times the likelihood ratio of positive. And I get a post-test. Now we're applying the test. The LR is the test. I've gone from a pretest probability to a pretest odds. Now I'm multiplying the pretest odds times the likelihood ratio, and I'm getting a post-test odds. Let's say we use 3. So this would be 4 times 3 is 12. 12 would be our post-test odds, right? Because I started with the pre-test odds, multiplied it times the likelihood ratio, now I got post-test odds. But I don't like odds, so I'm going to turn it back into a probability. Just like we did over here, except we reversed the mathematics, we take post-test odds and divide it by 1 plus the post-test odds instead of minus. So it's 12 over 13. I don't know what 12 over 13 is, but it is high. It must be 0.97. Anyone, grab your calculator. Pull up your calculator. What is it? 92.3. 92.3. Okay. So what have we done? We've gone from a pretest probability of 80%, applied this test, the ST segment elevation test, and came out with a 92.3. That's the lowest. That was the 3. Let's use 20. Let's use the 20, the highest likelihood ratio we found on Mr. Google, and let's go through the same thing. 4 times 20 is 80. 80 divided by 81 is 98.7. So we've used the biggest LR and the smallest LR that we could find on the internet, and we wound up 92.3 and 98. Does that matter? Is there a significant difference between 92 and 98? Is it, if you're already at 80, and if you're already at 80, you're probably going to send that guy right to the cath lab, right? And especially if you see an ST segment, man, they're going to the cath lab. But the post-test probability only varies 6 percentage points using the lowest and the highest likelihood ratios. So it turns out that unless something's really weird, unless 0.1 that you saw a while ago, unless one of these is 0.1, 0.1 would never work. I don't know where that came from. It would never work because it would make your pretest probability go down instead of up. If it's a positive number, it's going to go up. But let's see what would happen if we did this, if we were on, well, let's say if we were 20%. 0.25 times 3 is what? 0.75 divided by 1.75 is what? 42. Does everyone know what I just did? Take that 4, 1, or 0.25 times the likelihood ratio. So I took 0.25 times 3, 0.75, and I add 1 to it, divided by 1.75. And it's 42%. Let's do 20. What's 20 times 0.25? 5. 5 divided by 6? 83. Okay. So a large LR takes our pretest probability of I don't think they have it to, oh shit, they probably do have it. So if the LR positive is 20 and you're using it on a pretest probability that's low, it's really, really powerful. Let's do it with 3. Oh, we did it with 3, it's 42%. Is 42% enough to send him to the cath lab? Well, you don't know. You won't know that until you've been in the clinic a while. Laboratoire, 42% enough to send him to the cath lab? Or what do you do with 42%?
I'm going to look at other factors.
Going to look at other factors while simultaneously getting the cardiologist down there.
That's exactly right.
Simultaneously, you're going to look for another explanation because 42 is not really tripping your switch too much.
Observe.
What?
For
Put
serial
an observation.
troponins,
Could you?
24-hour admit serial troponins.
Yeah, there are a variety of things you can do in the middle of sending them home and taking them to the cath lab. There are a variety of other things you can do. But is it beginning to dawn on you how this stuff helps you support this subjective stuff we're teaching you to do? Clinical medicine is mostly subjective. And this diagnostic testing adds a quantitative, objective component to it, if you will. Okay? So I started this with saying the question is, how good's that test? How good's that test? And you don't want to stay, if the people around you are saying, well, sensitivity is, that is, specificity is, just give me the likelihood ratios. I can't deal with sensitivity and specificity, except I can create my own if you know exactly what it is. Mostly they don't know exactly what it is. Mostly they're kind of remembering, I think it's around 80, I think a 92, I don't know, maybe a 16, I don't know. If they know exactly what it is, you can calculate the likelihood ratio quickly. How good is the test? You need a likelihood ratio. The higher the likelihood ratio positive, the better the test is. The lower the likelihood ratio negative is, the better it is to rule out the disease. All right. Is everyone clear? This is the stuff you have to be able to know, I think, to pass the examination here in this program, and the examination on PANTS, and to use it at the bedside, and you can do all three if you just know the stuff we've talked about now. Okay. How do you get good at this? This is not something that will work by putting it aside tonight and say, I'll memorize this the day before the exam. That'll work to pass the exam. It won't work to be good at it. You got to use a similar process. So I would recommend that what you do is get with your study group or get with your friend or whoever it is you interact with in studying and say, we need to have at least an hour sometime in the next month to play with this. And you make up a scenario, you make up a test, you look up the LR on the internet, and you go through these calculations in your head. You should be able to do them in your head. The only ones I can't really do in my head very well is this last one where I don't know what 6 divided by 7 is. I know it's high, but I don't know exactly what it is. If it's over 90%, there are very few clinical situations in which I don't think I've got the diagnosis. Okay? All right, so now we're switching to something different. What I've been talking about for an hour is how to use a diagnostic test at the bedside. Okay? We're going to switch into something different. Now we have a paper that's about a diagnostic test. Someone has gone through and done all the work to put numbers in these 4 quadrants here and said, you know, how good is the ultrasound for the diagnosis of deep vein thrombosis? Something like that. So you want to know, well, so maybe you don't want to know. Maybe you don't give a shit. Most of the people I've been teaching this to for 30 years don't give a shit. I'll tell you my favorite story about giving a shit. About 10 years ago, I get a phone call. I'm at home, getting ready to eat dinner, I get a phone call. One of my residents who has been out about 10 years. She said, Dr. Banana, this is so-and-so. I said, yeah. She remember me? I said, of course. She said, well, I'm embarrassed, but I need to ask a favor. I said, sure, what do you need? She said, well, you know, you taught us the journal club and how to evaluate those articles and stuff. And I said, yeah. She said, well, I didn't come. I didn't come to journal club very often, and I don't know anything about it. I'm embarrassed. I want a job with CNN. I'm one of 2 finalists for a job with CNN to be their medical editor, their medical consultant that they bring on and talk about medical stuff. And there's another woman who's the second leading candidate, and the way they're going to make the decision about which of us gets the job is they're going to Skype us in on a debate about the data for the use of estrogen in the postmenopausal woman. I said, oh, it's a great question. She said, oh yeah, but it's scary when you don't know how to evaluate the literature. I smiled. Oh, revenge is so good. Bless her heart. I mean, she's got to do this in 2 weeks. Now, she doesn't know whether the other candidate is facile with this or not, but she realizes, oh, that's what they were doing in Journal Club. Do you think there's any way you could teach me how to do this in 3 or 4 hours? And I said, sure. We'll have breakfast 3 days in a row this week, and we'll get it done. We meet at Beverly's for breakfast, 7 o'clock. Spend an hour. You'll go home and do a bunch of homework, and then I say, have you got all these articles full? I've got them all. I said, perfect. Perfect. We'll do Journal Club. We'll do 3 years of Journal Club in 3 days. So here's a person who needs to know this isn't a diagnostic test issue. This is a therapy issue. Right? She needs to know, how do I critically analyze the literature for therapy? And there are some questions you have to ask yourself and have to answer. What we're going to do now is we're going to go through the questions you have to answer for a diagnostic study. The questions you ask are a little bit different for diagnostic studies, therapy studies, prognosis studies, okay? All right, so now we want to know, these people at Duke decided to do this study, so get this thing. Did they validly do this? Most of us say we'll spot those guys from Duke because all the people at Duke are smart. And so they did it right. But we know the data. The data are that the New England Journal of Medicine publishes 25% articles studied over the past 30 years. 25% of the articles in the New England Journal of Medicine are invalidly designed. That means that the answers to these questions come up No. Was there an independent blind comparison with the reference standard? The reference standard means a gold standard. This test that they were looking at, was there a comparison with a gold standard? Now, to answer these questions, you've got to go immediately to methods when you're looking at the article. Most of us ignore methods because we read the introduction to kind of figure out what's going on. Then we look at the conclusions to see what they found, and then we believe what they told us. The problem is, this is not the Word of God. This is some goofballs from Duke who did a study. They might have done it right, they might not have done it right. So the first question is, was there an independent blind comparison with the rest? That's a lot of information. And you read methods to see if they say, every patient who came in the ER suspected of having deep vein thrombosis underwent a venogram and an ultrasound. And the investigators were blinded to the results of both. Every patient had to get both studies, right? Otherwise, you can't fill out this 2x2 table. The people reading the venograms and reading the ultrasounds have to be blinded to the history and physical. And the investigators have to be blinded to these studies. And they have to be independent. You can't have, if you were going to get a venogram and an ultrasound, you'd probably send them both to radiology. But you've got to set this up so that those radiologists can't be talking to one another. They can't be talking to one another. Or what's going to happen is they're going to say, well, I've already done a sonogram on this thing, and those vessels are open. You don't need to subject this person to a venogram. Come on. That means the people who are making these decisions weren't blinded. So you got to make sure, was there an independent blind comparison with the gold standard? Did the patient sample include an appropriate spectrum of people? Where did you get these people? If they were all 80-year-old women who just got off an airplane with leg pain, that ain't going to work, because that's not who you see in your practice. What you need is a whole group of people who are coming through a family practice. Every patient coming to family practice at Integris with suspicion of deep vein thrombosis was sent for these tests. That's pretty good. That's pretty good because Integris has a huge primary care base, right? That's a pretty good sample of people. Was there selection bias? Selection bias means what they did was squeeze the leg, and if there was pain, they sent them for the test. If there wasn't any pain, they let them go home. It's called Homan sign. Squeeze the leg. Homan published before he died, my sign doesn't work for picking up deep vein thrombosis. And Homan sign is still taught in every medical school and every PA school in the country. It's horrible. But that would be selection bias. Was the reference gold standard performed in all cases, or did the result of the test being evaluated influence the decision? That's the two radiologists talking. I've already done a sonogram and it was normal, so don't subject them to that venogram. That damn thing's painful. It's invasive. The only way you can answer these questions is to read the methods clearly, because the researchers should have written down very clearly what they did. Were the methods of the test described in sufficient detail to prevent replication? So the way we nail things down in medicine is that if I read something done at Duke, and I'm not quite sure that's right, I reproduce it at OU. But I have to reproduce it with the same methods they used, or I can't compare apples to apples. So, was it described well enough that I could repeat it? And then what are the likelihood ratios? What are the results? So the results, we talked about this a little bit yesterday, the results of a treatment plan, a treatment article, are going to be relative risks and hazard ratios. The results of a diagnostic test are going to be likelihood ratios. And what I'm doing when I'm doing my 2-minute thing is I'm looking through there to see if there are likelihood ratios. They should have calculated it for me, because people who do this kind of work now know that sensitivity and specificity aren't good enough. Go ahead and calculate the LRs, and they should be listed. If they aren't, but they do have sensitivities and specificities, you can calculate it easily with the calculator on your iPhone. So here's the D-dimer. Does everyone know what a D-dimer is? Okay. So these are little fragments that come off of clots that are being broken down. And if you've got a deep vein thrombosis, your D-dimer ought to be elevated. So let's see, is it as good as the ultrasound? And so we do the study, just like we designed it. And here are your numbers. Okay, so you got some way to do some calculations. What's the sensitivity of the D-dimer? Anybody? 87%. What is the specificity of the D-dimer? 57%. What's the likelihood ratio positive for the D-dimer? Two. What's the likelihood ratio negative for the D-dimer? Did everyone get 2? 0.87 divided by 0.13. It's 2. It doesn't seem right to me. It is right? Wouldn't it be 0.87 divided by 0.13?
Yeah, 7.
Is that 2?
No.
No. It's what?
7.
Yeah. Yeah. So whoever got 2 must have used the wrong formula. It would be 0.87, the sensitivity, divided by 1 minus, the specificity. It'd be 1 minus, so it wouldn't be. It'd be 0.87 over 0.43. Yeah, it is close to 2. It is.
Somebody else gave me a wrong.
Yeah, I used the wrong formula. Okay, so it's 2. What's the likelihood ratio negative? 0.23. Okay. So those are the results, and those are the results you want to know. And if you can't do that in your head, you can certainly do it with an iPhone very, very quickly. If all they give you is the 2x2 table, you can calculate the sensitivity, the specificity, the likelihood ratio positive, and the likelihood ratio negative, and that's all you need. Now, this is real data from a real study, and so what has happened here is that they did the other study where they did the ultrasound as the test against the gold standard venography. Venography is so invasive and so painful that they really, really wanted a test that was non-invasive. They found that the duplex ultrasound was pretty darn good. It's not as good as venography, but it's pretty darn good. So now it's the gold standard. When they tested D-dimer, they used ultrasound as the gold standard. Does that make sense? It's not the truth, but it's approximate to the truth. And it's easier to do this study because D-dimer takes 1 blood draw and ultrasound is non-invasive. So it's easier to talk people into joining the study. Make sense? Okay. 2.23. Okay, got it. Now, so you just answered 4 or 5 questions. And you you wrote them down. What we're gonna ask you to do, the first exercise in evidence-based medicine is gonna be a diagnostic study. We're gonna give you a paper and you're gonna read it and you're gonna answer the questions we just done over. And you're going to fill out a form. It's gonna have the question, it's gonna have some boxes on the right side. And you're gonna fill out this form and you're gonna turn it into us and we're gonna grade it. Okay? We're gonna decide whether your answers and justifications for your answers, it would not be good to just say yes and no. You should write some things out there that justify your answers, whether or not they're acceptable or not. Now you've got some other questions that are less important than those first set of questions. Will the reproducibility of the test result and its interpretation be satisfactory in my setting? Can I do the duplex ultrasound or draw the D-dimer and get it evaluated in a lab that makes sense? Are the results applicable to my patients? So the way you answer that question is you have to look back at what was the population of patients that they studied, and do they reflect in some way your patient population? If this is a group of 80-year-old men and you're a gynecologist taking care of young women, it probably doesn't fit, right? Well, the results changed my management. And so you take those LRs and you rapidly run through the 80-50-20 scenario and decide, are the LRs on this, LRs positive and LRs negative for this test, do they move those pretest probabilities enough in either direction to make sense to me? And when they do make sense, you sort of store those LRs. I would store the LR positive on all the tests that you begin to use. You store them in your memory, or you store them in a data bank. There are data banks out there. When you Google LR positive for ultrasonography for deep vein thrombosis, boom, it's going to pop up. You can do it with your iPhone, so you don't have to carry around a list. Will the results help me in caring for my patients? That's the answer to those questions. Pretest probability times likelihood ratio. This is the form you'll be filling out. Okay, so now we're gonna cover just rapidly when you talk about, first of all, any questions about diagnostic testing. So we've done two different things this morning. One is how to use a diagnostic test. We do it with a pretest probability of 80, 50, or 20, and we do it with likelihood ratio. That's all we need. The second thing we did was go over the questions about how to critically analyze a diagnostic article, an article about a diagnostic test. When you study diagnoses, the second thing that comes up is screening. And screening has become a really hot topic. Can anyone think of a screening test that's been a hot topic in medicine recently? What?
Colonoscopy.
Colonoscopy. Yeah. Anything else?
Screening for Down syndrome.
What?
Screening for Down syndrome. And
Screening for Down syndrome. I haven't seen any hot issues about that.
There's a country that is doing it in their
Abortion
babies, all the babies with Down syndrome.
I
Killed
think it's Sweden. It's Sweden or Norway. It's one of those two.
recently?
Yeah, within the past, I don't know, 2 or 3 years.
Oh, you mean aborted?
Yeah,
They aborted the feces.
yeah. So they screen them.
Fetuses.
Yeah.
They aborted the feces.
Yeah,
Okay, so hot topic. Any others? Mammography? Big topic in the last 10 years. PSA, mammography. PSA and rectal exam for prostate disease, big topic.
Say pap smear.
What else? Pap smear, big topic. All right, so why are those big topics? The reason they're big topics is medicine grew up since the Middle Ages trying to be scientific. But mostly we didn't know how to be scientific in clinical medicine. We knew how to be scientific in the laboratory, but we clinicians didn't know how to be scientific. So we just muddled our way. And we made up stuff as we went that seemed like it made sense. At the end of World War II, I think, well, okay, you can take two views of this. One view is generous to medicine, the other view is cynical to medicine. End of World War II, medicine, someone decided what we should do is recommend to all adults an annual exam. Why would you do that? Well, we do that for disease finding, case finding. We know that high blood pressure is bad for you. We know that diabetes is bad for you. We know that high cholesterol is bad for you. We just have people, all adults, come in once a year, we'll go over all this stuff, and when we find disease, we'll start treating it, and they'll live longer. That makes sense, right? The cynical view is, if I can get all these 2,000 patients that I follow in my practice to come in once a year, let me go over all this stuff with them, charge them $200, I can pay for a new car. I can send my kids to college. It's not only makes sense, makes them more healthy, it helps me make cynical or not cynical. Then, sometime in the late 70s, the Canadians, why would the Canadians be the one to ask this question? Does this work?
Universal health care.
Because they have universal health care. The government says, wait a minute, we're paying the bill. We're paying the bill, and we're paying these doctors for all these annual exams. Do they work? What do you mean, do they work? I just explained to you why they work. The question is, does case finding work to do what? What's the outcome you're going to worry about?
Prolong life.
Prolong life. That's basically it. You die less soon if you find these things and treat them. So the Canadians started doing studies. And about 15 years later, the Americans started doing studies. But the Americans' studies are not being driven so much by the government because we don't have universal health care. They're being driven by other things, not as much by the government. Some. And they found out that the annual exam didn't work. You don't need an annual exam. What you do need is an annual blood pressure. You need an annual blood sugar. But I don't have to look in everybody's eyes, and listen to their heart and lungs, palpate their abdomen, and do a rectal exam. You don't have to do all that. You just don't. It doesn't work. Specifically, then we start finding out, well, what about the mammogram? Women with breast tumors who are under the age of 50, whose breast tumors were picked up by mammogram, and whose tumors were operated on, and who survived, are very effective activists. We all know someone, probably. My sister's one of them. And they are activists to the point that everybody with a breast ought to have a mammogram at 30. Because mine was picked up when I was 35. With a mammogram, well, it wasn't really. It was picked up because she found it in the shower and wondered about it, and someone did a mammogram, and she thinks it was picked up by a mammogram. And so, these female activists changed the way mammograms were used. Until someone said, do they work? And let's design some studies to see if they work. Turns out that mammograms under the age of 40, the findings of mammograms under the age of 40 as a screening test, not as a diagnostic test, as a screening test, which means everybody under the age of 40 with the breast comes in and gets one, picks up things that are followed up that cause more disease and more death than cancers that are cured. How does that work? It works like this. The mammogram picks up a lump, picks up a thing that looks like it might be a cancer, so the patient comes back to get a needle biopsy. You put some xylocaine in there, they have an allergic reaction to xylocaine and die. Shit! They were 38. They just died. And there wasn't even a cancer there. That's pretty rare. But what you're looking at now is every person in the society with a breast gets this done to them at 30. So it turns out when you really study it, you create more problems than you save. And so now the recommendation is unless you have a family history or unless you have a known genetic defect, you don't get a mammogram until 50, right? Isn't that right? It's 50. Yep. And the Komen Foundation doesn't agree with that. And the Komen Foundation will march every year trying to get it changed. But the insurance companies like it because they don't have to pay for all those mammograms at 30 and 40. But the data are supporting that. Same with PSAs for prostate cancer and digital exams. When I was practicing, I did a digital exam and a PSA on every man above the age of 50 every year. I probably found 2 or 3 cancers. Now it's just not done at all. At all. Because it turns out that many men die with prostate cancer. Much more men die with prostate cancer than of prostate cancer. It's such an indolent illness that case finding by screening everybody causes more deaths than prostate cancer does. It's counterintuitive. I said earlier, evidence-based medicine in many ways is counterintuitive. And this is an example of the counterintuitiveness of evidence-based medicine. So when you're thinking of a screening test, well, what's the evidence? When you're thinking of a vaccine, what's the evidence? When you're thinking of, a diagnostic test, what's the evidence? What's the LR positive? If you can show me a test that really reproducibly has an LR positive of 20, I'm in. Especially if it's non-invasive, right? It's 1.5. You can see from what we've been doing this morning, 1.5 is not so good. 2 is pretty good. 20 is awesome. Probably wasn't really 20. Definition: making early diagnoses of pre-symptomatic disease among well individuals in the general public. Early diagnoses in pre-symptomatic disease among well individuals in the general public. When applying the test to a wide group of asymptomatic individuals, we need clear evidence that the individual is better off if the diagnosis is made earlier. Boy, it seems logical that it would always be better to know, right? Or it seems like it. That seems logical. But early diagnosis labels people. If you have an early diagnosis that isn't going to kill you, or probably won't kill you, it labels you. What if I get a PSA that's high and someone says, "Oh, stick a needle in that prostate"? When it comes back, so you got grade 1 prostate cancer. Oh, now I've been labeled. I'm a guy with prostate cancer. Whereas before you stuck a needle in there, or even did a PSA, I didn't know anything. My prostate wasn't bothering me at all. Wasn't bothering you, wasn't bothering me, wasn't bothering anybody. Now, I got prostate cancer. holy shit, what am I gonna do? I'm gonna worry about it every hour of every day for the rest of my life, probably.
And your insurance is probably gonna go up.
Oh my
If you lose
goodness.
your insurance,
My
that's
insurance
gonna
might
be-
just drop me.
Yeah.
False positive tests. True positive tests are sick longer and receiving treatment longer. I had a wife die of gastric cancer, stomach cancer, in 2009. And she had some gastric pain, some stomach pain, abdominal pain, about a year before she was diagnosed. It was really odd. The story was we were at a football game in Norman. I bought a couple of beers on the sidewalk. And we opened them and started drinking them, and she went, oh my God. And she'd been drinking beer all her life. She said, oh my God. And she just took that beer and threw it away. I said, I don't know what that is, but man, I mean, that caused horrible pain. And pain went away and didn't happen again. And next time she drank a beer, it didn't happen. And, she had a couple of things cause some gastric pain or some stomach pain during the year. But her internist said, I don't know what that is. It went away? Yeah, it went away. I don't know what it is. And then she started developing abdominal pain that didn't go away. So her internist said, let's do a scope. Let's look down there and see what's going on. So they look down there and they find cancer of the stomach. But it turns out that cancer of the stomach is almost always lethal from the time it's diagnosed. Doesn't matter when you diagnose it. It's already spread so widely in the peritoneal lymph nodes that it's gone. So the question in her mind and my mind was this gastric cancer a year ago when I drank that beer in Norman? Why didn't it happen later when I drank it? We don't know. We don't know. Would it have been better had we scoped her a year ago? The data are, all it would have done is label her earlier and she would have gotten treatment earlier. And in my opinion, she would have been remarkably miserable for 16 months, whereas she was moderately miserable for 5 months and died. She's going to die, probably, because she has a disease that doesn't respond to therapy. She's probably going to die no matter when you get it. So does early screening help her situation? You look back, say, well, that was a pretty good year she had. She wasn't worrying about having cancer every day. She didn't have her stomach cut out. You know? So these are counterintuitive issues that are real, that we don't normally engage with. And sometimes they're not things you discuss with your patient, you know, when they're sitting on the table, because you might come across as seeming uncaring. But there are issues that we need to grapple with as practitioners, as a society. Okay, so for screening, the questions are, is there a randomized control trial? Is there evidence based on a randomized control trial that early diagnosis really leads to improved survival and or quality of life? That's really the outcome. If you're talking about a screening test, you say, is there evidence that this will lead to increased survival or quality? Are the early diagnosed patients willing partners in the treatment strategy? You already know what the treatment's going to be. If people are going to turn down the treatment, we probably shouldn't screen them for the disease, right? Do the frequency and severity of the target disorder warrant the degree and effort of expenditure? And so that's not a practitioner's question. That's someone who now graduated from PA school, practiced 5 or 6 years, and is now in Washington helping the government develop healthcare policy? Do the frequency and severity of the target disorder warrant the degree and effort of expenditure? Should we spend money on this? All right, so we've already done this pretest probability, we've already done post-test probability, we've already done 2058, we've already done this, we've already done this, we've already done this. Boy, don't you like it when the last part of the lecture was already done? Okay, so this is ultrasound and venography, like we started the lecture. And this is ABCD. So tell me, what's the, based on this 2x2 table, what's the sensitivity of ultrasonography? %. Okay. What's the specificity? 90 what? 99%? Well, that's a pretty good test. So if it's 91% sensitive and 99% specific, what's the likelihood ratio of positive? What? 91? Everybody get that? What's the likelihood ratio of negative? .1. Okay, so we've got a likelihood ratio positive of 90 and a likelihood ratio negative of .1. So let's just play with that a minute. If your pretest likelihood is 90%, you're going to use 1 as your multiplier. And you're going to use, if you're trying to rule in disease, you're going to take the 1 times 90 and do what with it? Divided by 91. You've taken your pretest probability of, you've taken your pretest probability of 50% and turned it into what? What's 90 over 91? Huh? 1-ish? So it's around 100%? It's pushing up against 100%. So you've gone from 50% to 99% as your post-test probability. This is a damn good test, right? And what if you're at 50% and your test is negative? Your ultrasound is now negative. All the vessels are compressible. You've gone from a 50% pretest probability of 1 times 0.1. 0.1 over 1, 0.1 is what? Huh?
I got lost on points.
You did?
Yeah.
Okay, so likelihood ratio negative is 0.1. And we're starting with a pretest probability of 50%. The number we have to remember for a 50% pretest probability is 1. We take that times the likelihood ratio negative. 1 times 0.1 is 0.1, right? And now we divide that by 1.1, because we add 1 to it. What's 0.1 divided by 1.1?
0.09.
90.
0.09.
0.099%. So it's 9%. Now you've taken your 50% pretest probability down to 9%. And the question is that helpful? Probably is. Probably is. I was at a coin toss. I did an ultrasound and I compressed all the vessels. It was negative. There's only a 9% chance now that they have deep vein thrombosis. What am I going to do with that result? I'm not going to tell the patient, you do not have deep vein thrombosis. I'm going to say, the likelihood of you having deep vein thrombosis is now only 9%. It's really low. So it's best for us to look for another explanation for your symptoms. Whatever it is you're complaining of, we ought to look for something else. Because 9% is not very, it's not high enough to subject the person to anticoagulants for 6 weeks, right? So you always have to think of what we're going to do is look for something else to explain these symptoms. All right, so get with your study partners run through this enough times so that you've got it in your head. I just need you to remember 4.1.25. I need to find the likelihood ratio, either calculate it off of the sensitivity and specificity, or find it on the internet, and then run through these calculations, okay? And that's a diagnostic test. We're going to give you a paper, and you'll be going through it'll have the form with it, so you'll know what the questions are. You'll practice going through the methods and figuring out what the answers are to the questions, okay? All righty. So we're done, and we were scheduled till, oh, question.
Yes, I'd like to go ahead and ask a question and have a follow-up. Number one, was the resident capable of learning this in the 3 one-hour breakfast sessions? My follow-up is, did she get the job?
She did pretty well. She was a really bright gal. She did pretty well at doing what I asked her to do each evening, and so I don't know what the distance was between the third session we had and her Skype. She did not get the job, and she told me that she didn't know why she didn't get the job. She thought she argued the case of the data pretty well, and she thought she told me that she thought she was good enough at analyzing. She was as good at analyzing these papers as the other person was. I don't know whether that's true or not. But she thought she got enough in 3 days. I think it's like anything else. You know, your ability to learn something is directly proportional to your need to know. Right? That's why seeing patients is so powerful. We go to the hospital, we see some patients, or we go to the clinic, we see some patients, we go home and we start learning. There's a whole new category of therapy, chemotherapy, called immunotherapy, and most of the new stuff is not coming out of immunotherapy. Immunotherapy was, of course, invented after I quit seeing patients. About 3 or 4 years ago now, my daughter-in-law developed a glioblastoma. My oldest son's wife developed a glioblastoma, and so as he and I are talking about this, he said, I need you to be in charge of helping me understand therapies. You need to help me and Jill understand it. Holy shit, I don't know anything about this stuff. I said, no problem, I'll get it done. And so, not only did I get on the NIH website and look at every study that's out there for glioblastoma, when I would read them, I didn't know what I was looking at, because there's all this terminology and all these molecules I didn't know anything about. But by the end of about 2 weeks, I was facile with discussing immunotherapy for glioblastoma. Need to know, got to get it done. And I think she did that. You know, she probably wasn't good at it long term, and probably didn't ever need it again, be my guess. But when that's why you're so good the night before an exam. There's a need to know, and you know it's a need to know, and so your brain kicks in and gets it done. The problem is it just puts it in short-term memory, and so you don't necessarily remember it for long term. All right. I'll see you in June.
Black, like when it's falling, it's like.
For this little baby.